webinar. My name is Emily Lubring, and I'm the Director of the Federal Programs Unit with the oversight of our waivers. And today we're going to go over some changes to the waiver regarding the value-based payments for our providers. Today we'll go through a timeline of our milestones as we've worked towards value-based payments. We'll also talk about how the budget for our value-based payments are in relation to value. And then lastly, each of our leads for our incentives are on the call today to go over the value-based incentives and explain a little bit more about each one. So I'm going to start off by going over, on the slide that you're seeing right now is a timeline of our key value-based milestones. Value-based payments are a payment approach that offers states a way to transition a system of payments from quantity or reimbursing providers per each individual service based on value and moving to a based on value and quality of services. So if you look at this slide, you can see all the way on the left-hand side, fiscal year 2019, the division started the process of moving towards value-based payments and planning for value-based payments by receiving a grant to work on the value-based payments. And then as we work across the timeline, we've done some revisions to our employment services to get ready for value-based payments. And then in Q3 of this 2022, the General Assembly or legislation, the state of Missouri approved budget items to include value-based incentives or value-based payments. And then we move into fiscal year 2023, which is Q1 where we're at right now, where my unit, FPU, has been working closely with the leads for each of the incentives to develop language to submit or to add to our waivers to support value-based payments, with a plan of starting the implementation of our value-based payments beginning of January of 2023. So about 6 months or so from now, hoping to plan to implement those with the approval of CMS on our waiver amendments. So then a little bit about our fiscal year, our 2023 budget for value-based payments. This next slide gives you a kind of a visual picture of how the division sees us moving from 2022 to 2023. The flower on the left-hand side of the picture provides where we are at in fiscal year 2022 and where we're moving to in fiscal 2023 with our budget and our incentives and a plan for our division. For instance, you can see the red flower petal, the baseline wages for stable workforce. That was red in 2022, starting in fiscal year 2023, which is actually July 1st of 2022. You can see that we moved that from that red to on the right-hand side, you'll see that we moved to the green, meaning that we've implemented baseline wages, and that's that $15 DSP wage that was implemented with the General Assembly approval of our budget. You can also see how we've moved from standardized rates, which were orange, which is in progress in 2022, and in 23, we've moved to green for implementing standardized pay rates for our service providers. So we keep moving in a direction to make improvements with our services in this model. So where does this take us as a big picture for the division and for our individuals and families and other stakeholders? We look at the big picture for our division for value-based care as improving individuals' outcomes. It includes rewarding those providers who facilitate quality outcomes and being good stewards of use of our money, our budget. So when you look at each of those three items, you'll see we kind of put under each one of those improving individual outcomes, healthcare access, quality and intervention, improving that through a health risk screening tool, the HRST, and we'll talk about that more today. Tiered support, which is also one of our incentives that we're implementing. And you can see through social and community inclusion, we have listed remote supports. And one of our incentives that we'll discuss today is around remote supports. And then if you look into this middle category, rewarding and facilitating quality outcomes, we have a skilled workforce where we're rewarding DSP training levels, encouraging our DSPs to complete additional training, to registered apprenticeship, which also encourages it's a mechanism for our DSPs to learn best practice, which DSPs direct support professionals. Along those lines, for a stable and accessible workforce, we have the NCI Staff Stability Survey, which is our national core indicators, and you'll hear more about that incentive also today. And then in the last column, the great public stewards, we have accountability, efficiency, and transparency. Well, in that category, we're looking at an EVV, or an electronic visit verification incentive. So as a whole, the division wants to work towards payments that encourage value, quality, efficiency tied to value and quality. The next section our next part of our presentation will be each of the 9 incentives that we're proposing for approval by CMS. Each of our leads will go over those 9 incentives and explain why the incentive is important, kind of how it works, and then how those tie together with what I just showed you as our big picture for our division on value-based care. So the first one we're going to talk about today is the HRST, or the Health Risk Screening Tool, and I'm Kim Stock with the division. Will explain this one.
Thanks, Emily. Good afternoon, everyone. So the HRST.
Kim,
Yes, can you hear me?
A little bit louder. Thank you.
Okay. The HRST stands for the Health Risk Screening Tool. And the why behind this particular initiative is to incentivize applicable providers to initiate the MODD HRST screening process prior to current targeted statewide implementation, which is currently May of 2023. The HRST, the Health Risk Screen, is a tool used to provide early detection of health risk and destabilization for individuals. The completion of the HRST, the Health Risk Screen, will align with the individual's annual Individualized Support Plan, or ISP, meeting. The HRST information will serve to support the team with the identification of implementation strategies to mitigate risk and improve health outcomes for the individual receiving services. The who, in regards to who this current VBP initiative applies to, is current DMH-DD contracted waiver residential service providers and TCM providers serving individuals receiving Division of DD 1915C Home and Community-Based Services, or HCBS waiver services. What they'll be receiving is a standardized one-time payment rate that's calculated at $72.20 for the completion of each individual's initial health risk screening tool during the identified time frame. We've also provided a link, a direct link on this slide that will give you some more information in relation to the Missouri HRST project. Next slide, please. And at this time, I will be turning the presentation over to Rhea Evans, who will be speaking regarding tiered supports.
Excellent. Thank you, Kim. Good afternoon, everybody. I'm going to talk through the tiered supports incentives. A little context before I go through the why, who, and what. Hopefully, many of you have heard of tiered supports before. It's something that the division has been interested in for about a decade now. The way tiered supports works is it's a combination of a standard assessment that looks for components of best practice for universal positive behavior support, and it's combined with ongoing consultation that division staff offers to agencies to help them build up those best practice components. As we're moving toward value-based purchasing, we're going to separate those two things. The payment is going to be based on the best practice components, and consultation is going to be separate from that. So providers won't have to work with us to earn the payment, but they do have to have best practice positive behavior support in place. When you look at the why here, we know we have 10 years of data that shows that when you have these best practice positive support elements in place, what you get is a lot less challenging situations. People have a better quality of life. There's less restrictive interventions, less of a need for law enforcement or hospitalizations. There's less staff turnover. So the data shows that really having these components in place really does lead to a better quality of life for individuals, for the provider, and for the staff working with them. So who does this? Well, the payment is for any service provider agency that's providing individual supported living service. We wanted to open it up to more, but that's where we're going to start with this time around. And the payments are two separate payments. We have our monthly payment for just giving us data. Even if the numbers are 0, it still counts as giving us data. As long as you fill out our data elements on the online form, you will get a monthly payment of $174. And then separate from that, we have a quality payment. And that is based on the level of implementation of those key positive support components. And that is a maximum of $15,000 if you are fully implementing. If you are moderately or medium implementing, it would be 70% of that. And if you are low implementing, it would be 40% of that. And that would be on a quarterly basis. And this slide here shows you the tool that we are going to build into the online form for that quality payment. This does live on our tiered supports webpage. So if ISL providers wanted to log in and self-assess to see whether they would currently qualify for low, moderate, or high, they could do so. Like I said, it's going to be housed on an online form. We've tried to make it as objective as possible, so there's no room for interpretation. And as with all of the other payments, these are set to start January 1st of 2023. And now I'm going to turn it over to Wanda Crocker, who's going to talk to you about remote supports.
Afternoon, everybody. On remote supports, we've developed a value-based incentive. It's truly a cost savings model, but it's being housed or covered under the value-based incentive payments. So it's slightly different in how it's calculated. But the who is any individualized supported living and in-home respite provider who has transitioned or will transition from paid staff support hours to remote support hours, which results in an overall reduction in budget due to reduced staffing hours. The what is a 15% payment of the state share of savings for each 6-month period. So the state share is currently 33.99%, and they would get 15% of that percentage. Why would we be doing the value-based payment? There is an increased independence. We have success story after success story posted online illustrating people who have been using this service as far back in some cases as 2012. Stories of people who have very difficult life challenges who have been very successful in using remote supports. The why is also a reduction in stress level of overall DSP, not only a reduction in stress level as in a provider won't need as many staff, but also a reduction for the individual staff person who maybe actually is to focus on helping people or teaching skills instead of generic oversight. They're there when the person really needs them, not all the time. And of course, many providers are developing career paths for their DSPs through implementation of remote support systems. And of course, last but not least, there is a savings to the state when a provider implements remote supports in conjunction with other services or instead of other services. The win is, oh, I think we lost the slide.
The win will be
Well, there was a slide with
beginning.
when and how. So a couple before that. So our slides are all kind of mixed up. But I'll go over the when and how anyway, because we're supposed to. And we were playing with the slide deck this morning. I think maybe we deleted something we weren't supposed to. The when, like many of the other value-based payments, is starting January 1st of 2023 for state fiscal year 2023. Meaning if approved, it would go back, we would be looking in January at savings incurred for the fiscal year starting July of 2022. How is the savings going to be calculated? It is a savings on it's based on the month, calculated monthly for the previous 6-month period, and a provider may earn the quality payment up to twice a year. So we would look at the last 6-month period and look at it month by month because each month could incur a different savings depending on the support that was in place during that month. The next slide is supposed to be the how. I don't know if that is in there, Emily. The slide you're showing is actually the one after the how.
Yeah, so we have an abbreviated slide deck for
Aha.
audience.
Okay. So the how of how we're doing remote supports is, again, we're looking at the savings being calculated for each of the 6 previous months of the calendar year. The provider may earn the quality payment up to 2 times a year, meaning that if they submit an invoice in January for the first 6-month period for an individual, they would also be eligible to submit an invoice during the second 6-month period for the same person if remote support remained in place and a savings was recognized. And how we're going to do that, there's a couple of different ways because it impacts both ISL services and respite staff. So in conjunction with when remote support is implemented with ISL services, after the ISL services were implemented, we would be looking at the hours of authorized to the individualized supported living in the month prior to the initial remote support implementation at the current unit rate reimbursement. So what we're showing you right now is what I'm going to go over next and give you some monetary actual numbers to look at because sometimes it makes more sense there. But for some of these people, we'll have to go back to 2012 to see how many hours of support were they getting prior to sorry, trying to read and speak at the same time. prior to the implementation of remote supports. And then we will subtract the current hours of remote supports and any remote supports in place to come up with what that quality incentive, what that savings was. We also have a scenario where when two services are implemented simultaneously, so someone's new to ISL services and they're implementing in conjunction at the same time with remote supports, we would assume for the savings context, what the person would have paid for their share of 24-hour supports if we had not implemented remote supports. And when we implement remote supports and respite, we would be looking at the average number of respite hours per month in the previous year, because respite is not a standard standing line item, so we would have to go with the average. So on the slide that Emily is showing here, it is an illustration of how we would actually do that. So this is an illustration of someone who came into remote supports in fiscal year 18. They were getting one-on-one, 24 hours a day, just to simplify. And the hourly rate in 2018 was $17.50. So the monthly rate was $12,775. Today, that same budget would cost us $26,506.30 because the fiscal year 23 hourly rate is now $36.31. So we would bring, what would that cost us today if it implemented? And then in the yellow is all of the items that we're going to subtract from the orange. So we would look at what's their budget today in ISL. So they decreased from 730 hours to 486. So that now costs us $17,670. We would subtract the amount of response center if one exists per month, and of course the technology component. So in this scenario, there's a total savings of $6,395.71. The state share of that is $2,173.90, and the value-based payment, the 15% of the state share, and then the 6-month payment for this example would be $1,956.51. So that's a really quick rundown of the math. It is just one example. I did the easiest 730 just to represent hours, but there are many different scenarios and will have to be individually evaluated. And so now I am turning it over to Heike to talk about DSP training levels.
Thanks, Wanda. I am, as Wanda said, here to talk to you about the DSP, the Direct Support Professional Training Levels. Who is this for? This is for any waiver service non-licensed professional staff delivering contracted HCBC services, including, and we have a nice long list there for you. That'll be up on the screen. We have this posted on our webpage, so I won't go down through that and read all of those to you. Why are we offering these DSP training levels? We know that with that training and staff retention goes hand in hand. Employees will gain national best practice skills, and we're also looking at the mitigation of risk and improved individual outcomes. So with the next slide, what is it? This is training that's provided in an online learning platform that's powered by Relias. We have that available for folks to access with an access point being on our division webpage, as well as contracted providers that may have their own sub-portal that they can use to access that. There are 3 payment levels with this incentive. The first payment level is a 1% of claims, and there is a typo on the slide, so everyone hear me. That percentage should say 90%, not 95. So it should read that it's 1% of claims when 90% of DSP workforce that's been there for 6 months and has completed the level 1 DSP training. So 2 pieces to that: 90% of staff that have been there 6 months and have completed level 1 training. There's another 1% of claims when 50% of the staff that has been there with them 6 months and have they've completed, maintained level 1, and then 50% have reached that level 2 training. and then another 1% when they've reached 50%'s reached 1% or level 1 and level 2 training and maintain that, and then have completed the level 3 training. And for that one, it changes from 6 months tenure to 1 year tenure. That has to be with the same agency. So quick recap, 3 levels, level 1 training, 6 months tenure at 90%, level 2, 50%, 6 months. The level 3 is level 3 training, 50% and 1 year. So, and providers can receive that quality payment twice a year. And then I forgot, we have an abbreviated slide deck. So with that, I will transition us into the registered apprenticeship, which I will tell you that we have worked very hard to make sure that our training levels also help to support this incentive, which is the registered apprenticeship program, again, for HCBS waiver service providers. They can participate in the direct support professional registered apprenticeship program. That includes a one-time payment of $1,560 when 50% completion, and one payment of $1,560 with successful completion of the apprenticeship program. And again, with that abbreviated slide deck, I want to make sure that I don't get too ahead of myself. I will tell you that registered apprenticeship program is a combination of training courses and that align with those training levels that we previously discussed, as well as more of an on-the-job hours of learning. And then why? We know that investing in those folks and making sure that we spend time in investing in that helps to build a talent acquisition pipeline that increases staff retention, employees gain national best practice skills, and again, there's mitigation of risk and improved individual outcomes. And the other incentive that I want to share with you is regarding employment reporting. Again, HCBS contracted employment services providers for this one. What is it? It's a payment of $55 for reporting as outlined in the provider contract. This payment is only for a service reporting episode where the provider completes 100% of the activities report containing all the required data points. So we want that information. We want folks to provide that to us, and this incentive will give you something in return for that. And why? As it says, incentivize providers to share data. Then that data can be used for benchmarking performance to inform future development of value-based payments. And with that, I believe that I will pass the baton back to Kim Stott.
Thank you, Heike. The next initiative that we'll be speaking about today is the National Core Indicator, or NCI Staff Stability Survey. This is a particular survey that the division has participated in for several years now, and who it applies to are current DMHDD contracted 1915C, home and community-based service through the waiver providers. And so the providers are providing residential services, in-home, and non-residential services. What they will be receiving through this initiative is an annual lump sum payment of $2,000 per qualifying provider. And the intent is to incentivize providers to participate in this annual survey to gain information. And it is, again, on an annual basis that this NCI Staff Stability Survey is completed. The National Core Indicators, or NCI Staff Stability Survey, collects specific information on the direct support professional, or DSP workforce in Missouri. It includes information pertaining to staff wages, retention, and turnover. This particular survey and the data that's provided supports the division's policy and program development to enhance the retention efforts and training needs of the DSP workforce. The next initiative, I'll be turning over to Emily Lubring to speak about electronic visit verification, or EVV.
Thanks, Kim. So our last one to discuss today is our electronic visit verification. And if you receive, or one of your loved ones receives, personal assistant through our agency, this is an incentive for those agencies to provide the correct information that should be sent to with the electronic visit verification. So the incentives for any agency personal assistant that successfully connects and transfers the required verified records to our state system. If you're familiar with that, if you've had somebody, your PA provider come in and say they have to clock in, clock out through an electronic method, it is a requirement through the federal government, CMS, for that electronic clocking in and clocking out, ensuring that the PA, the personal assistant, is with you during that time, and that they're supposed to be scheduled. So with that, we are incentivizing or encouraging our agency providers to make sure that they're submitting at least 80% or more to the claims system with the correct information, the correct electronic visit verification, sorry. The payment that the providers will receive is at least 2 times a year. And they would receive 1% of the payments that they have submitted that have been paid with correct information on that electronic verification. So why is it important that we encourage our providers to be successful with those electronic visit verifications? Electronic timekeeping is a best practice. It adds efficiencies, provides quicker payments to our providers, allows for better coordination of care, easier scheduling for time, and then minimizing some billing errors that can occur. So our incentive is to encourage our agency providers, and this is not an incentive for our self-directed PA providers, just the agency, for this incentive to make sure that they are submitting the required 6 points or 6 data points that they have to for the federal government and the state requirements. So that concludes the presentation today regarding our 9 incentives that the division has put together for approval by CMS. Kind of wanted to go over quickly a reminder how we talked a lot about provider payments today related to these incentives, but how it all works together with the big picture. If you remember, recall, one of the pieces of the pie was improving individual outcomes. And how we see that working together with these incentives is we incentivize our providers to provide the best care they can for our individuals through, for instance, the health risk screening tool. It's a way to detect health risk in individuals' health risks and ensure that proper care and support is identified and can be addressed. And then for instance, the tiered supports, it also incentivizes our providers to develop systems of best practice to support our individuals for a higher quality of life. So if we can incentivize our providers to use that system or that process for tiered supports. And remote supports is about encouraging independence for our individuals if it works for that individual. Like Wanda mentioned, there are story after story of how it has been successful, provided independence for our individuals, fills in maybe some gaps or making a feeling of security or safety that they may need. And then our training levels that we're incentivizing our direct support providers to encourage them to more training for better outcomes for our individuals, to see that training then translate into improved care, as well as the apprenticeship for our direct support providers. So that's just some of the background of why we've picked some of these incentives to work on. The staff stability that Kim talked about encourages providers to share data with us about their turnover rates, their pay rates, so that we can learn from that and what things our providers are doing to keep individuals employed, to decrease turnover, which we all know it also leads to better individual outcomes if we don't have additional people coming in to homes to keep consistency. So that's our presentation for today. I don't know if we have any questions from our families and individuals today.
I didn't see any, and I answered the one that came up.
Okay, so on the screen right here, if you do have questions about value-based payments, questions about the specific ones that we have planned and looking to get approval from CMS, or just in general how value-based payments work, you can send an email to the dd@dmh.mo.gov email box, and with the subject line of VBP or value-based payments, and we'll be glad to answer any questions. So I appreciate your time today and say goodbye. Thank you.